Thank you, guys. Well, thanks a lot. Appreciate the introduction. Anyway, we're going to talk to you guys. I'm a member of the Lake Physician Group with Dr. Chastain here. A great group of doctors all working together to help all of us people in the Baton Rouge area. Anyway, we're going to discuss today colon cancer, and colon cancer is really a preventable disease. We're going to discuss why I think it is. You know, if we undergo the appropriate screenings or look for the appropriate signs, there's a great chance that we can prevent this disease. And this is the #2 cancer killer in the United States. And this is a disease that really hits home to me and my family. You know, I treat colorectal cancer almost every day, but my own sister, who Dr. Chastain knew as well, died of colon cancer at age 52. And she was diagnosed with a very advanced colon cancer at age 48. And she probably had some symptoms, you know, in retrospect before that, maybe could have been screened sooner. But this was a young, healthy, beautiful girl, as you see. This picture was taken not too long before she died, probably within a year before she died. No medical problems otherwise. So how do we prevent someone like my sister from getting a cancer or treating a polyp or whatever could have been there first, prevent her from dying like she had to die? And I think she would have wanted me to try to help others prevent what she went through herself. Let's go through anatomy first. This, you see depiction of the body on the right. You have I'm sorry, the pointer really doesn't work, but the liver up here, stomach, this is colon, small intestine. This is the depiction of a polyp within the colon. This here also shows you as well, the appendix is probably something you've heard about, the ascending colon or right colon, transverse colon going across, your descending colon and your sigmoid colon and your rectum. The rectum is actually the last 6 inches above the anus. Go through some facts, you know, the most up-to-date facts that we really have about colon cancer. It's estimated in 2015 there's going to be over 130,000 cases of colon cancer, new cases of colorectal cancer in the United States. And that's 8% of all new cancer cases. Estimated deaths in the United States in 2015 is approximately 50,000. That's pretty much been the same for several years and years. So there's 50,000 deaths from this cancer every year. And that's a percentage of all cancer deaths, 8.5%. And if you look at some of these other facts down there, pretty interesting. The risk of developing colorectal cancer for any of us is about 4.5% within our lifetimes. And the prevalence of colon cancer in the United States in 2012, these are the most recent tabulated facts here. You see that almost 1.2 million people living with colorectal cancer in the United States. So this is a significant problem. If we can prevent it, we can prevent a lot of more symptoms, morbidity, and mortality or death for many people here in the United States. If you see here, this chart shows that colorectal cancer is the 4th leading cause of cancer, but it's the 2nd leading cause of cancer death in the United States. So we're talking about significant disease process. How do we stage colorectal cancer? Well, you know, it's not really staged by the size of the tumor. You know, it's actually by how thick it goes through the colon wall, and I'm going to show you some diagrams of this. What is the thickness through the colon wall, and whether or not lymph nodes around the colon tumor are involved, and also whether or not there's distant spread. So if you see here, the first stage 0 is really not invasive cancer. That's, you know, cancer-like cells, but within the lumen of the colon and have not penetrated more deeply. That really, you know, is kind of a risk factor, but that is not really a cancer itself. So if we can find something early on like that, we're doing great. You know, a patient really would have no significant risk of any recurrence if we can catch it that early. T1 and T2 would be just partially through the bowel wall, not completely through. And a stage 1 would be a T1 or T2 without any lymph nodes involved. And I'm going to show you some diagrams of this as well. A stage 2 is when the cancer is through the bowel wall and even through the bowel wall involving other organs around the colon or rectum without lymph nodes. Stage 3 is a node positive cancer, and it can be any thickness through the bowel wall, but there's a lymph node positive stage 3. Stage 4 is if there's distant disease. This shows you a little diagram of what this means. Stage 0 is kind of what we call high-grade dysplasia, carcinoma in situ. It's more, you know, it's almost penetrating through the submucosa, but it in and of itself is not a cancer. You know, at higher risk of getting cancer in the future, and those patients need to be screened more carefully, but it's not cancer yet. Stage 1 is partially through the bowel wall. Stage 2, as you see, is completely through the bowel wall. I'm sorry my pointer doesn't work. If you see here in the lymph nodes that are in the fatty tissue around the colon, if those are involved, it's a stage 3. Stage 4 is distant disease and involving the liver, involving other organs distantly away from that primary site of the tumor. This shows you another little depiction of it. You see the stage 1 above. It's not all the way through the bowel wall. Stage 2, you see it's through the bowel wall. In stage 3, you see the lymph node basin around this area with some enlarged nodes and evidence of cancer. So what does that really mean, stage 1, stage 2, stage 3? Well, obviously, the more advanced the cancer, the harder it is to treat, and the lower the survival. So, the 5-year survival is what we use to describe cancer, okay? The 5-year survival of localized cancer, or really a stage 1, you can beat that really almost 90% of the time, possibly even higher than that. So if we can catch something earlier the better. Stage 2, through the bowel wall, still your odds of recovering for this are great. Some of these patients may need chemotherapy, but greater than 70% will be alive at 5 years, which means there's a great chance of cure. But if there's regional, meaning also regional would be included with that if there's lymph node positivity as well. Okay, so we're talking about a great chance of still cure from that if the patients do everything that we ask them to do. Distant disease, obviously, if it's spread beyond the colon, chances of cure are going to be less, but there's still more and more we can do now than we could in the past. In unstaged, there are many patients that are found to have colon cancer after the fact, but still, obviously, earlier staging is much better. If we can make a diagnosis earlier, the chance of being cured is much greater. So what are the risk factors for colorectal cancer? Well, obesity, high fat intake, increases our risk, no doubt, increase our risk of other cancers as well. High red meat consumption increases our risk as well also. Alcohol and tobacco, even as few as 2 drinks a day, alcoholic drinks a day, can increase our risk of colon and rectal cancer. Tobacco is really not good for anything. Tobacco increases, or nicotine, tobacco, etc., increases our risk of multiple cancers. And the sedentary lifestyle, lack of exercise really increases our risk too. And I'm going to show you some other facts about this. Low fiber diet, processed foods are not good for us because there are nitrates in the processed foods that increase our risk of bowel cancers in general. Gastric cancers, probably small bowel cancers, and definitely colon cancer. Personal history of colon polyps or colorectal cancer, we're at increased risk if that's true. I'm at increased risk because of my sister. I've had a polyp myself. Other family members have had polyps, so I'm in a higher risk category myself. Family history of other genetic problems, which I'll describe briefly. Lynch syndrome is a genetic problem that can be associated with colon cancer and other cancers, and also a personal family history of polyposis syndromes, which I'll describe too. Syndromes where we can have multiple polyps in the upper GI tract and in the colon and rectum, which can be associated with significant increased risk. So let's go through these different risk factors and, what do we need to know? What can we do about it? How do we prevent colon cancer ourselves? Or how do we know if we're higher risk and need to be screened earlier than a typical age or more frequently than typical screening? At age 40 to 50, all of us, even without other risk factors, begin to display increased risk in colon cancer. And the risk really increases progressively through the rest of our lives. At age 50, there's a sharp rise. 90% are diagnosed with colon cancer after age 50. From age 60 to 79, 50 times higher than age less than 40. So as you see, as we get older, the risk of colon cancer goes up significantly. Personal history of other diseases. Many of you have probably heard, or maybe have family members, maybe even yourselves, have a history of ulcerative colitis or Crohn's disease. These are called inflammatory bowel disease. If a person has that, they are significantly at higher risk of having a colon and rectal cancer. As you see here, this taken from 2007, I think these numbers are still accurate. With ulcerative colitis, there's about a 2% risk after 10 years of disease of having colon and rectal cancer. As time goes on, that's greater, 8% after 20 years and 18% after 30 years. Crohn's disease, there's probably also a very similar increased risk of colon cancer. So if someone has either of these diseases, their colon, and they have colon involvement, their colon needs to be screened at a much earlier age and more frequently than those without any personal history or history at all. Having a personal history of colon polyps, somebody in here was telling me earlier that they have colon polyps themselves. And if a person really has a history of colon adenomas or true precancerous polyps, serrated adenomas would be another type. What are you guys doing? Those type of polyps are associated with significant risk of us getting cancer ourselves. So never should a patient with that kind of history go longer than 5 years without a colonoscopy, in my opinion. So personal history of polyps, removed polyps, a personal history of colorectal cancer. Obviously, we have a significant risk of getting a cancer again. We need to be screened more frequently. So we'll discuss here the personal history of colon cancer. After a curative surgery or resection for colorectal cancer, regular surveillance or follow-up colonoscopy is needed to detect new cancers that can come about. Let's see here, metachronous primary colon cancer. So if we have a history of colon cancer ourselves, after a cancer surgery, we're probably going to have the next scope at a year. If everything's fine, 3 years then, and then if everything's fine, then 5 years. Never should that patient go longer than 5 years. And there are certain types of genetic traits, problems that are going to necessitate screening a lot more frequently than that. Family history of colon polyps or colon cancer. 20% of these patients with colon cancer have a family history of it. So all of us ought to go home, look into our family history. You know, mom, dad, brothers, sisters, have they had polyps? Have they had cancer? Things that can increase our risk and get us in to get screened soon. You know, first-degree relatives with colorectal polyps are significantly higher risk. So who really needs to be screened more carefully? First-degree relatives less than 60. Those who have 2 or more first-degree relatives with colon cancer or polyps at any age. So really, it's first-degree relatives or relatives with polyps or cancer. A lot of us know about cancer risk in the family. Not a lot of us have asked about brothers or sisters who've had colon polyps. Lynch syndrome, we'll kind of touch this briefly, but Lynch syndrome is one of the hereditary cancer syndromes that can be associated with the risk of many different types of cancer. So we may say, well, I don't have a family history of colon cancer. Nobody in my family has that. But yet we have a family history of uterine cancer, ovarian cancer, small bowel cancer, certain types of liver cancer, certain types of kidney cancer. These cancers are all linked together, and if someone has this syndrome with these different genetic findings here, you'll see on that third line, they could be at increased risk of all of these cancers, and they may need to be screened every year. So that's why knowing our family history is very important. If we have a family history of many different cancers like this, they ought to get to their primary care doc, ought to get to one of us, ought to get to a GI doc, to look into help them look through their history a little more closely. You remember what my sister had told me before she died? You know, she would like me to help others prevent what she went through. You know, so the way to help prevent that is to find those who need to be screened earlier than the typical age of just age 50. So Lynch syndrome is the single most common explanation for hereditary colon cancer. Now, these Lynch cancers aren't, you know, it's only 2 and 4% of all colorectal cancers. But, you know, as you see here, these different genetic traits, those who have Lynch are going to get cancer at a fairly young age, still in their upper 50s. So screening for them needs to be much younger than the typical age of 50, or you're going to miss cancer in these patients. Other organ systems need to be screened too if they have it. Their GYN area, their uterus, their ovaries. Pancreatic cancers can be at higher risk, you know, and certain kidney type things too that need to be probably at least thought about or looked into. So the polyposis syndromes, what did we, you know, I discussed there are certain syndromes where people can have many colon polyps, many upper GI polyps too. So if you know of any family members who have something like that, let your primary care doctor know about it because you may need to be screened earlier too. These type patients will definitely 100% if they have full-blown familial polyposis get colon cancer by age 39. So they need to be screened very early. Almost all will have cancer by 40. Aggressive screening should start at a young age, 10 to 12. So if mom has that, we need to look at kids. If dad has it, we need to look at brothers and sisters, kids, etc. You know, their colon and rectum probably needs to come out in their early 20s or earlier, maybe in their late teens. And they can have a risk of upper GI problems too, cancers and polyps. So a GI doctor needs to look in their upper part, you know, their stomach and their small bowel. There are some lesser type syndromes like this, but still with associated increased risk, attenuated FAP and MYH polyposis. They have later onset, lower cancer risk, but they're still significant. These patients need to be screened a lot more commonly. And I do surgery on all of these patients to help prevent them from getting cancer. This just shows you here, the full-blown, the attenuated FAP and a MAP or MYH polyposis. The attenuated ones, a lot of times we can avoid resections if they have very frequent scopes. I'm talking scopes by the time they're 40 almost every year, almost yearly, to remove polyps and prevent them, prevent cancer. But if we get to the point where we can't remove polyps with a colonoscope, then they need surgery so they don't get cancer. So these are things we all need to know about. Remember, our family history is very important. A lot of people don't know our family history. Even a lot of us doctors haven't looked deeply enough into it. So, how do we avoid colorectal cancer? How do we prevent it? Because that's the whole goal of this talk, is how do we prevent people like us getting cancer, the number 2 cause of cancer death in the United States. Avoidance of processed foods. We already saw that processed foods increase our risk. Unfortunately, the unprocessed foods are more expensive. It's probably a good investment for us. Lunch meats, things like that can stay in the refrigerator for months without going bad. Well, there's a reason for that. There's a lot of chemicals in there that keep them from going bad. So healthy, fresh foods are better for us. We could even buy things that are not processed that are going to be better for us. More expensive, but better for us. And it's all within, some of us, there's no doubt, are going to have some of these things in our diet, but if we can limit them to the best of our ability. Avoid obesity, low-fat, high-fiber diet. We do know that, excess weight on us probably is associated with increased cancer risk, multiple cancer risks, associated with, different risk in women and men, but definitely colon cancer is increased risk. Low alcohol intake. We know there's a study that has shown that even 2 alcoholic drinks a day increases our risk of colon and rectal cancer. No tobacco. Like I said, tobacco is not really good for anything. Cigarette smoking, cigar smoking, dipping, etc., associated with multiple cancers. Not good for us. Associated with multiple other medical problems. Exercise. We know from research that exercise is associated with a decreased risk in colorectal cancer proportional to the intensity of our exercise. So by the intensity that we go out and do exercise, and any exercise is better than nothing, by the intensity that we do it, we decrease our risk, no doubt. So kind of what our mom told us when we were kids, eat healthy, be healthy, exercise, you'll live a healthier, longer life. She was probably right, no doubt about it. Genetic factors, knowledge. We need to have a knowledge of our personal or family history. Do we have any of these syndromes in the family, or just are there any cancers? What are the cancers that we have in our family? Not just colon cancer. Remember the uterine, ovarian, certain types of other cancers. We even know of an association with breast cancer and colon cancer now, which may be associated with an increased risk. Prostate cancer, we're even seeing that there may be an increased risk, but there probably is too. So this is the kind of information your doctor needs to know, so they can help you get the screenings you need. Appropriate screening is the key, and genetic testing, if indicated. And I do a lot of genetic testing through my office for patients that I find to be at higher risk. Dietary factors. Saturated animal fat is implicated in carcinogenesis or cancer production, So we need to limit the amount of fat that we have in our diet. And invariably we have to have some fat, but we can have healthier fats. Countries with a higher fat intake have a higher colon cancer rates. And we know this, that we have transplants from other countries like the Far East where they have healthy diets. When these people bring their families to the United States, where by and large our diets aren't as healthy here, these people develop the cancer risk that we have here. So it just goes to show you we can decrease our risk here by eating healthily and eating low-fat foods, etc. Red meat, high consumption. Literature shows that is associated with increased colorectal cancer rates up to 28%. Processed meat, high consumption is associated with 20% increased risk of colon cancer. So let's avoid the processed meats. Limit red meat. Red meat once a week is probably not bad, but red meat every day, probably bad. Common sense, okay? And the red meats that we do eat, we can get the leaner red meats. There's leaner ground beef. There's some other leaner cuts of meat that are going to be a little healthier for us. Fruit and vegetable intake. Studies show that high intake may be associated with lower colorectal cancer rates. Once again, something Mom told us when we were little, eat your fruits and vegetables. She was probably right. Fiber. Regions of the world with higher fiber content have lower colorectal cancer rates. Conflicting evidence in trials, but observational evidence really shows this. Once again, these people from these countries move to the United States and they eat less fiber. They have the same cancer risk we do. Okay? Increased fiber decreases the transit time in our colon, lessens the time of carcinogens or cancer producing substances in the colon. So things high fiber, there are fiber supplements we can take, but if you just think of good leafy vegetables, whole wheat bread versus white bread, there's even been some studies that have shown the increase in cancer rates since the advent of white bread, which came about in the early 1900s. I mean, white bread is probably not, tastes good, but it's probably not very good for us. Whole grains, whole grain oatmeals, things like that are going to be a lot better for us than things without fiber. Physical activity and obesity. Higher rates of physical activity associated with lower rates of colorectal cancer. This is a dose-response effect. Intensity and frequency are associated inversely with risk. Well, and one of the reasons we do know is that exercise increases our colon health and it increases gut motility. I take care of patients with chronic constipation too. Some of these patients, if we can get them on more of an active exercise type cycle, their constipation will get better. Once again, if we're more regular, that's less time that these cancer-producing substances in our gut will be there. That's the theory. Obesity, there's inefficient energy consumption associated with increased risk of colon cancer. So we all need to try to, eat healthy and lose weight if we need to. Cigarette smoking not good for anything, I have to say. It's just not. The carcinogens or the cancer-producing products in tobacco increase our rates of colorectal polyps and cancer. Up to 12% of colorectal cancer deaths are attributed to smoking. That's pretty significant. So most people think of lung cancer. They're not thinking of the other things that smoking can affect. Earlier age and onset of colon cancer as well. And smoking can affect our surgery too. Cigarette smoking can affect healing rates after surgery. It can affect lots of things. In fact, a lot of our patients, we like to get off their cigarettes for close to a month if we can before we operate on them. But with cancer, we don't have that time to wait very often. Alcohol consumption, occurrence at a younger age. Metabolites, acid, aldehyde are carcinogenic or cancer producing. And like I said here, 2 or more drinks a day associated with increased risk. Increased risk with increased intake. Moderation is the key to life, obviously, right? Screening, incidence decrease because of screening, the incidence of colon cancer seems to be decreasing in our country from the age 50 on up. So screening seems to be helping in the screening age. And the normal screening age is 50 without patients, without having symptoms, without having other issues or family history. But it's in the age 20 to 49 where we're seeing an increase in incidence in colorectal cancer. Why is that? Could it be obesity? Because we have restaurants everywhere we go, fast food all over the place. Are our kids eating less healthily than we did? I don't know. That's a possibility. Diet, genetic factors. And also, many of these patients probably need to be screened earlier based on certain facts that we do know. The best screening test is a colonoscopy. That's probably the easiest procedure I do. I'll do all the big surgeries for colon cancer. But colonoscopy, we do it, all the GI doctors do it. The best test to help screen us. If you see here, this is just a depiction of someone lying on their side. They're sedated. The scope is passed around to remove polyps. You remove polyps, you shouldn't get cancer. 95% of the time, colon cancers start as polyps first that change over kind of a long period of time and become a cancer. So if you remove the polyps, you shouldn't get a cancer. It's the one screening test that's actually a preventive test. Every other screening test that we have for our bodies just tells us we have something. This can prevent. This shows you a depiction of a colonoscopy as well. You see some polyps, you see the cancer, the divertic. We can make diagnoses of other processes that may need attention or may need changes for us. This is a depiction of the inside of the colon from a colonoscope, and this is something we do all the time. This shows actually that transverse colon. If you remember from my picture, the part of the colon going across, it usually has a triangular shape. That's why this is a colon cancer. It has the ugly appearance there. This is another colon cancer. So what are the recommendations for screening, say, in an average risk individual? Those without symptoms, those without personal or family history. And I'll say this and I'll say it again later. Anyone with symptoms, with bleeding, with blood in their stool, major change in their bowel habits, certain types of abdominal pain, need to be screened almost at any age. Because these can be signs of polyps or cancer that we need to look into. The U.S. Preventive Task Force in 2008 released some guidelines, which are pretty much still the same, but there's, some physician and patient discretion involved too. They recommend using fecal occult blood testing, sigmoidoscopy, or colonoscopy. I'll say colonoscopy is the best test in adults beginning at age 50 and continuing until age 75. The risk and benefits of these screenings may vary. They also say from age 76 to 85, there may be consideration that support colorectal cancer screening in individual patient. I would agree with that. We don't, age is to me is not necessarily as important as the health status of the patient. I've got some 85-year-olds that are like 50-year-olds. I've got some 50-year-olds that are like 90-year-olds. So, I think it's kind of a dangerous thing when we're setting cutoffs because of age. That's almost discrimination in my book. So, but they do leave some leeway there. They also say, at age 85 or above, it's unlikely we screen these patients. But there's still some patients in that age group who have a history of cancer, who have major symptoms, who we screen, and we find cancer sometimes in these people. And they want surgery, we'll operate on them. We operate on 90-year-olds. Many of them do very well. So age to me is not necessarily a cutoff. I think that's just a dangerous thing when we're cutting things off because of age. There's some other things. They talk about the benefits. There's something called CT colonography that was CAT scan colonoscopy that was developed years ago. It's a decent test, but exposes you to radiation, and most insurance companies don't cover it for screening. We'll talk about that a little bit. And there's fecal DNA testing, which actually you probably read about that last year. There's a new DNA test that's pretty good. We're not exactly sure where that fits into the whole screening recommendations. Earlier age evaluation. Who needs to be screened before 50? Well, like I said, symptoms: rectal bleeding, blood and stool, change in bowel habits, abdominal pain, almost any age. You need to talk to your doctor about it. You might need to be screened. These could be symptoms of something we need to look into. I had a patient who was 40-something, having rectal bleeding. He thought it was just hemorrhoids. Scoped him, he had a rectal cancer. He had a rectal cancer that he needed pre-op chemotherapy, radiation. I did major surgery on him. He finished his chemotherapy. I did another completion surgery. He's doing great. But, if he would have gone two or more years without making this diagnosis, this cancer could have spread and, would have threatened his life. So he's doing great now. But symptoms are something we need to look out for. The body's telling us something when we're having symptoms. Family history, obviously, like we already discussed. Colorectal cancer, colorectal adenomatous polyps, the polyposis syndromes, the Lynch syndromes, the other cancers in the family, right? Try to beat this home. Ovarian cancer, uterine cancer, small bowel cancers, even certain types of brain cancer in the family can be associated with increased risk. Certain breast cancers, certain prostate cancers. Your doctor just needs to know your whole family cancer history, okay? The guidelines, what about for those that really, or what do we recommend? A cancer prevention test should be offered first, and that's preferred. A colonoscopy is preferred, okay? You're beginning at age 50 in an average risk individual. Those without a family history, without a personal history, without any symptoms. If you've never had a colonoscopy, you've not had many of these risk factors, 50, we all need a scope at 50. I had a patient the other day who had nice guy, great guy, smart guy. He had his first scope at age 65. I found a 10-centimeter mass in his rectosigmoid area. If he would have been scoped at age 50, probably never would have. I may be able to remove this with a scope. He may need surgery. So it just goes to show you, if he would have had a scope at age 50, that would have been a little polyp probably, or something that, would have gone screenings, we would have prevented this. Cancer detection test. The test should be offered to those who decline colonoscopy or another cancer prevention test. Preferred cancer detection test is the FIT stool test. Now the Cologuard, the DNA test, is probably the preferred one, and we'll discuss this some. Colonoscopy is still the best test, though. But if someone's going to refuse colonoscopy, we want you to do something. We want you to do something to get evaluated. Alternative colorectal cancer prevention test. There's a short scope, but that's only looking at half the colon. We know that over half the time the cancers come from the other side. So that's not going to be the whole. That's not going to look at everything. The CAT scan colonography, but like I said, insurance companies and Medicare, they don't pay for that for screening. They do pay for it for other reasons, but it is exposure to radiation too. Alternative cancer test. There's an annual hemoccult test the fecal DNA testing, which I'll discuss too. So fecal occult blood testing, collection of blood samples sent to the lab. There are food and medicine restrictions. Eating certain things are going to give a positive test. Taking certain medicines will give you a positive test. So there's specific instructions you'll have to follow. Fairly inaccurate. There are false negatives. On average, only a 30% detection rate. So it's better than nothing. It's cheap. But just because it's negative, don't get too excited about it. Put it that way. The FIT test is a stool test that is better than the old traditional fecal occult blood test, and it tests for hemoglobin, which is part of the red blood in the cells, more sensitive than the fecal occult blood testing. There are no food and medication restrictions, and it's more expensive than the fecal occult blood, but it's a better test. This is a study which just looks, if you see the red, I'm sure it's small, comparing FIT versus the old fecal occult blood. The FIT is much better. And just in finding a cancer, it's 87.5% versus 54%. Finding a significant or advanced adenoma, which really they say an advanced adenoma is a polyp greater than a centimeter or greater, that it's 42% versus 23%. So it's a lot better than the old fecal occult blood test. The stool DNA, which you may have heard about, was in the news significantly last year. This finds DNA within the stool that would be associated with cancer or polyps. And it's much better than the other stool tests. It's more expensive, but it's much better. 92% of colon cancers found. Also found 69% of high-risk precancerous polyps. In basically both false positives and false negative tests were found. 13% of the patients without it are tested positive. So it's not perfect. And any positive test still needs a colonoscopy, obviously, because you need to go in there and try to find where the polyp or the cancer is. And how do you follow up these patients? In my opinion, where does this fit in? This fits in for those who refuse colonoscopy. It's probably the next, and for those who refuse colonoscopy or refuse maybe a barium minima and a short scope, it's probably the next best thing. If they won't do any invasive test, this is the next best test. Now, Medicare, it is covered by Medicare. Many private insurance companies are covering it now. There is some expense. It's about $600. So what about screening those who have a family history of the other genetic problems I told you about? How do we screen those? If there's a single first-degree relative with colorectal cancer, advanced adenoma diagnosed greater than 60, well, this says still screen at age 50, but there are other guidelines that say if you have a colon cancer in a first-degree relative, you would really start at 40 and then go to normal screening. So it is significant even if mom had cancer at age 70. Your doctor needs to know about that. Or dad had any of these. Remember all these other cancers too we talked about that can be associated. A single first-degree relative with a colorectal cancer less than 60 or an advanced adenoma, meaning a polyp greater than a centimeter, but even you may not know the size. You're going to just know they have precancerous polyps probably. Or two first-degree relatives with colorectal cancer or advanced adenomas. Those patients should be started at age 40 with their screening. Never should go more than every 5 years. Or 10 years younger than the age of the diagnosis of the youngest affected. So what if your brother had cancer at age 40? Well, you need to start your screening at age 30. Okay? So this is why the family history is very important. If you wait to 50, you're 20 years behind. By the time they scope you could already have a cancer. Okay? What about those with the familial polyposis syndromes, the FAP? If genetic testing is not done, those patients should start with their short scopes or flex SIGs at a very young age. As I stated before, and many of these patients are going to come to colon resection, rectal resection to remove their cancer risk. So that history is in the family. Your doctor needs to know about it because you're going to need to be screened at a young age, no doubt about it, especially if it's brother, sister, father, etc., significant risk. Patients with the remaining rectum after surgery is done need to have their remaining colon or rectum screened pretty frequently. And those with the classic FAP in whom genetic testing is negative should undergo genetic testing for another problem, that MYH polyposis I told you about, which is another one. It's not new now, but was new in the early 2000s. We know a lot more about it now. So, and even if someone has a history of 10 adenomas in their lifetime, these are the precancerous type polyps, you really should undergo genetic testing. to see if you have one of these attenuated polyposis syndromes, attenuated FAP or MYH polyposis. Those with hereditary non-polyposis syndrome, those who meet criteria for the syndrome that we find, we'll really go through all those right now, should undergo further genetic testing. And if they're positive, their family members should be tested, to show. And if they really do have one of these traits, then they need to be scoped very frequently. It says every 2 years in their 20s, and as they get older, they're different types. But when they get into their 40s, most of them need to be scoped almost yearly then. And cancer cancer surgery, preventive surgery may be recommended for them at some point. The CAT scan, you probably have heard about, why can't I just have the CAT scan for screening? Well, insurance companies don't cover it. It's pretty decent, but they can't remove any polyps. If they find something, they have to remove it. In my experience, there are false positives. Sometimes stool shows up as a polyp. If there are any positive findings, you have to have a colonoscopy still. And there is radiation exposure. We don't really want to have repetitive CAT scans if we don't have to have them. We do know that the cumulative radiation exposure can affect us. If we have to have scans for our medical treatment, fine. But if there are other options, it's probably better to use something else. There is an option for it, though, if there's an incomplete colonoscopy, if we can't get around. That's a good idea. One other thing about it, there's no sedation. Whereas colonoscopy, you're completely sedated, you're out. What about colonoscopy? This is the best screening and preventive procedure, and even in the 90s, you saw that pretty much all of the polyps of a centimeter or greater were recognized. The small ones, most of them were recognized, 16% weren't detected, but a less than 5 millimeter polyp is really associated with negligible risk. 6 to 9 millimeter polyps, still the majority of them were found. But colonoscopy is not a perfect test. If someone has a colonoscopy, it's okay, and 2 or 3 years later you're having significant bleeding or blood in your stool, we ought to do it again. It's a good test, but it's not perfect. And in my society, my national society, the American Society of Colorectal Surgeons, in 2011 gave a core subject update. There's this 1 centimeter or greater, only 2.1% of those will be missed. In the 5 to 10, only 13% will be missed. And the very small ones, certain ones will be missed, but those are less significant. Well, like I said, it's not a perfect test. There are many reasons. There can be prep. It can be prep-related. There can be a little portion of stool that can't be removed. So this has been proven over the years. It's the best test. But it's not a perfect test. But there's certain things we do, and I'll show you to make it a better test. Now we use high-definition screens, which allow us to see better. And we do have something called a split prep, which makes it better too. So even in the best hands, my whole point of this is that you have a normal colonoscopy. 2 to 3 years later, you're having blood in your stool, significant symptoms, you might need to be scoped again.
You're not going to miss some babies.
You're not going to, you should probably, the risk something big would be very unlikely. Like it said, the miss rate of something greater than a centimeter would be very unlikely. A centimeter or greater, 2%. So that's still possible, but it's unlikely.
What's a centimeter in relation to an inch?
An inch is 2.54 centimeters. So a centimeter is about this big. Small. Yeah, well, it's a little less than half an inch. So split dosing, I just told you, the split prep is something that increases our detection rates. That means when you do half the prep, and the preps are a lot better than they used to be. We don't ever do gallon preps anymore. It's a lot less volume to drink. If you do half the prep the night before and half the prep in the morning before, you got to get up early, but the prep is better, and I've got some data to show this. Sorry, this one's a little hard to read, but if you just look at this conclusion at the bottom, originally primary care docs had apprehension about their patients having to do part at night and wake up early in the morning, but really then they found the patients really tolerated it better, and we see better. So if you do part of it at night, you have your bowel movements, you rest, you go to sleep, you do part early in the morning, most patients seem to tolerate it better. And this was a study which shows the optimal bowel cleansing with colonoscopy, a split dose, a series of looking at all kinds of different controlled studies. Basically what they found that split dosing, and particularly if the second dosing is taken before 5 hours before the next scope, the prep is much better. We've provided further evidence of the superiority of the split prep dosing over non-split dose regimen and showed that regardless of type and dose, the superiority of split dose regimen remains valid if the golden hour rule is preserved, meaning if that last dose is within 5 hours of the scope. Even though you have to get up, we see a lot better. And it's like night and day. I used to do them with the more traditional all the day before. There was always stool in the right colon. So that's one way you can miss it. If there's still stool in the colon, it's harder to see, especially a small polyp, right? Okay, so you can see why the small polyps can be missed if we're not cleaned out appropriately. That's why the prep is important for us to do right when we get scoped ourselves. Surgery for colorectal cancer, this is where I come in. We do all the big surgeries. We do the scopes. That's the easiest thing I do. But we do all the big surgeries when people have cancer or have advanced polyps. The most of what I do is minimally invasive or small incision related surgery. It's rare nowadays we have to do the big stem to stern incision. It's still possible, and that's okay if we have to. But by and large, we're doing minimally invasive or small incision approaches. This kind of is a depiction of some of the ports we use with a smaller incision. This shows an example of healing better than the old stem to stern that we used to. And patients seem to recover a little easier too. It's still a big surgery on the inside, but they recover a little easier. Hand assist laparoscopy is what I do a lot of. It is a minimally invasive approach, but allows us to use our hand too, especially for cancer and getting real high to remove all the lymphatic areas. I think it's a great approach. Here's a depiction of me. Patient gave me permission for this. Picture of me doing a hand assist laparoscopic surgery on someone who actually had attenuated familial polyposis. She had one of those polyposis syndromes. I removed, but she didn't have cancer. We're going to prevent her from getting cancer because we found that she's young. She's in her 40s, I believe. So she had the attenuated type. This is a depiction of me removing some of the fatty tissue along the colon. What about robotic surgery? Where does robotic surgery play into this? Robotic surgery, basically all the data has shown, and I'm a robotic trained surgeon, but all the data has shown really that basically robotics for colorectal surgery is another avenue to do a small incision surgery. It's not necessarily wrong. At this stage, is it better than what we were doing before? No, it's not, but it's another means to go about doing it. The data has shown that the results are equivalent. So if your doctor wants to do robotic surgery on you, that's okay. But if your doctor wants to do another minimally invasive approach, that's okay too. For me, the hand assist laparoscopic approach, I've done hundreds and hundreds and hundreds of them, have had great results. It's a good approach. So robotics is here to stay. It will continue to evolve. But, right now it's another means of getting the small incision surgery done. It's not necessarily the best way or the only way. There are many approaches to go about it. Transanal endoscopic microsurgery is something we do too. Believe it or not, it's where certain types of early stage rectal cancers can be removed from below without making any incisions on the belly at all. And advanced polyps can sometimes be removed this way. This is a scope. It looks big. It's about this big. But don't worry, the person's asleep when they're having this done. And this gives you a depiction of us removing the polyp this way and closing everything up. Sometimes this just serves as a super biopsy because sometimes this isn't enough, but sometimes it is enough for adequate treatment. And anything we can do to avoid major incisions is good. Where does chemotherapy and radiation come in? Well, I'm not a chemotherapy doctor. I'm not a radiation doctor. I am a cancer doctor. I'm a cancer surgeon. I'm a colorectal surgeon, and we work hand in hand with the radiation oncologists and the cancer doctors at Marybird Perkins. Great doctors. There's, for node-positive colon and rectal cancer or metastatic disease that has spread, obviously chemotherapy plays a part. Obviously, even certain types of colon and rectal cancer, there aren't node-positive where chemotherapy and radiation will be needed. Radiation is rare for colon cancer, but for rectal cancer, pre-op staging is very important. Okay, pre-op staging is very important for rectal cancer. If your doctor says, well, you really need radiation and chemotherapy prior to surgery to decrease your risk of recurrence, to decrease your chances of having a distant recurrence and increase your odds. If someone is found to have a stage 2, meaning through the bowel wall, mid or low rectal cancer, remember that, or stage 3, having what we think are enlarged lymph nodes preoperatively, those patients need chemotherapy and radiation prior to surgery. So in conclusion here, what do we need to do? People don't think of colon cancer as a preventable disease, but it really can be. We can prevent it, or we can diagnose it at its earliest stages. And if you saw earlier at its earliest stages, your chances of cure are great. Even if we diagnose it in its latest stages, you do have some pretty good chances. We need to diagnose it and treat it. How do we prevent it? You know, avoidance of processed foods, avoid obesity, low fat, high fiber diet. Let's try to eat healthy foods. Let's try to eat fresh foods the best we can. Some of us, you know, we're on the go and we can't always eat at the best, but even when we're traveling, even when we're in the car, driving around during the day, there are healthier options we can get even at McDonald's, even at Burger King, you know. Rather than getting the fried chicken sandwich, we can get the grilled chicken sandwich. So no matter where we go, there are better options for us. There are better options for us. Exercise, let's all get in an exercise program. Decrease our risk of colorectal cancer proportionally intensive our exercise. Exercise is also good for our heart, good for our longevity, and prevents many disease processes. Genetic factors, knowledge of our personal and family cancer history. We need to all go home, find out what our family cancer history is. Not just colon and rectal cancer. Remember, uterine, ovarian, small bowel, certain types of liver, certain types of CNS, brain, certain types of prostate, breast, you know, kidney. Many of these things can be associated with colorectal cancer and increase our risk, give us a need to be screened sooner. Some of us may need genetic testing because of the family history we have, okay? Appropriate screening, as I've stated, we've gone over that significantly. Genetic testing is indicated. One other thing I want to add are anybody with significant rectal bleeding, blood and stool, significant rectal bleeding, abdominal pain, change in bowel habits. You know, you go every day for 20 years, and then all of a sudden you go once every 4 days. Yeah.
It's significant. It's a lot. You know, it's constant.
Well, I would say any of you guys, anybody here having rectal bleeding probably needs to let their doctor know. You know, probably just needs to let the doctor figure that out.
Oh, okay.
But for the most part, you know, now there you can, if you we look and see obvious hemorrhoids that are bleeding, there's an obvious fissure, that's one thing. But many times rectal bleeding in our book is just an indication to do a scope and make sure. You know, because the polyps or the cancer can cause bleeding. Okay, and then genetic testing is indicated. Symptoms, remember, symptoms we scope at any age. Just want y'all to all leave with that. And that's really about it. Let's, you know, like my sister told me, you know, let's do what we can to help prevent those from going through what I went through. And colon cancer is a difficult, tough thing in the advanced stages.
A gastrologist, I've known the specialist, you said what you are, but a gastrologist, is he the first person you wind up going as a physician?
Well, a gastroenterologist, I mean, yeah, I mean, well, a gastroenterology, they're great docs. We work hand in hand with them. That's a subspecialty of internal medicine. You know, they do they do scopes. They don't do all the other surgeries I do, but they do scopes. They do upper scopes. They do colonoscopies. You can have your scopes done by a gastroenterologist. Screenings can be done by them. We do them too. You know. Well, there are many good. There are many great you know, most of our gastroenterologists here in town are very good. They're very good. You know, we do screenings too, but you know, we don't try to take patients from the gastroenterologist as well. But what we do, I mean, many people haven't had scopes. They're welcome to come to me. You know, we're glad to take care of them.
Well,
we work hand in hand with the
gastroenterologist. You don't have
gastroenterologist.
to have a general physician to recommend.
No. You can just, depending on insurance, you can come directly to us.
Where are you located?
I'm part of the Lake Physician Group. I'm in the next to the Outer Lake, the Plaza 1. I'm in Suite 206 in the Plaza. You know those two big buildings, the two big office buildings there?
Okay, I went to the one on Jefferson.
Those are very good docs there.
My question is this, and I'm going to say it like this,